I would like to introduce the first panel. And that panel, the discussion is, or the topic rather, is enhancing the Nigerian Human Capital Index. How do we understand the trends in the healthcare sector? The discussions will be about or around changing health patterns in Nigeria and innovations that are paving the way to improve the health indices. And to moderate this panel, I'd like to invite Ms. Idejibuno, a friend of mine, who we both went to school together. I don't know, I think there are a few Queen's College girls in the area.
I'm going to be surrounded by two doctors today. Dr. Kechi, please join us. And Dr. Olurotimi. Okay, so I'll happily introduce the two doctors that surround me today. No, I'll go ahead. I can do it. Thank you, first of all, for making the time today. I know that everyone's really busy, and this is a full-day schedule. And I'm glad I'm going first, and I have the opportunity to capture your imaginations and have us all pay attention to a really important issue. I'm joined today by Dr. Olurotimi Badero, who's a Nigerian-American physician. He's an interventional cardiologist and interventional nephrologist who has been recognized as the world's first and only fully trained CardioNephrologist, which is a heart and kidney specialist. Honestly, a round of applause for that. This is Nigerian greatness right here. Having completed an unprecedented 10 years of continuous postgraduate medical training, specialization in 7 different areas of medicine, Dr. Badero currently holds 6 specialty board certifications in the field of medicine. Dr. Badero is currently the only fully trained board certified cardio-nephrologist in the world today and has received several awards in Africa, Europe, and America for this achievement. Dr. Badero performed the first transradial cardiac catheterization and percutaneous coronary angioplasty stenting. Honestly, I'll be a doctor by the end of this. In the history of Central Mississippi Medical Center and River Oaks Hospitals in Mississippi. Dr. Badero is the Executive Director of Cardiac, Renal, and Vascular Associates and is on the Global Advisory Panel of Therapeutic Experts on Thrombosis and Atherosclerosis in the world. Dr. Badero has authored many peer-reviewed articles and sits on the editorial board of several international scientific journals. Thank you very much for joining us today to talk about human capital. And Dr. Kechi Achebe, who I had the pleasure of meeting just maybe a year ago, is the Senior Director, HIV/AIDS and TB at Save the Children, US. She provides technical and managerial leadership for the HIV/AIDS and TB unit within Save the Children, USA. She is also responsible for overall management of the HIV/AIDS and TB program portfolio and delivery of technical support to Save the Children's programs focusing on HIV/AIDS prevention, treatment, and care for people living with AIDS and TB globally. She leads the team in providing technical support and quality assurance for HIV/AIDS and TB technical staff and programs in over 50 countries as well as at headquarters. Dr. Achebe earned an MD at the University of Benin in Nigeria and received an MPH in International Health with an emphasis in infectious and non-communicable diseases from Boston University School of Public Health. A licensed medical practitioner, she was awarded a certificate in finance and management in international health by Boston University, and she completed a research fellowship in infectious disease epidemiology at the Boston Medical Center in Massachusetts. A fellow of the Royal Society of Tropical Medicine and Hygiene, she serves as an advisory board member of the International Institute of Health Technology Development, IIHTD, and is a member of the advisory team to the Civil Society Board of UNITAID. She is a member of various professional groups, including Stop TB WHO Partnership, the International Association of Physicians in AIDS Care, to name a few. Her work has allowed her to combine her commitment to public health service with an opportunity to further examine the ways eliminating health ways of eliminating health disparities throughout the world. Thank you very much for joining us. So it's my pleasure to moderate this panel on human capital in Nigeria. And before I turn to the panelists, I just wanted to share just personally how troubling it was to me to find out last year when the World Bank launched the Human Capital Project that we were 152 out of 157 countries that were surveyed when this index was created on human capital. And what this index measures is the amount of capital, human capital, that a child born today can expect to attain by age 18, given the risks of poor health and education that prevail in the country where he or she lives. The index measures each country's distance to the frontier of a complete education and full health for a child born today. The fact that we're 152 out of 157 is so disconcerting because it's not about us, it's about these kids. Imagine their future in a world where technology is taking over. What future for them? Will they really be able to compete in tomorrow's world? And that's why I think this session is so important, where we'll hopefully have an opportunity to ponder some of these concerns, and especially the relation to health. So I'd like to kick off by asking Dr. Olurotimi your views on this. I mean, how do you think Nigeria is performing on health generally, and what do you think about our score on the Human Capital Index? I'd just love to hear from you what you think.
Well, thank you, distinguished ladies and gentlemen, guests. It's an honor to be here amongst everybody as we celebrate this Nigerian Heritage Day inaugural edition. As we look at the 59 years of the independence of this country, I'm sure you will agree with me that we've made some progress in some areas, we've become stagnant in some, and we've actually declined in some others. Gone are the days where I remember I was always conscious of the very ambiguity of the concept of exceptionalism and a global mandate for a country where you see all this, what you see now is just embattled faces and falling eyebrows. But one thing that always keeps us together is the shared vision, the collective goals that bind us together as Nigerians, and that DNA is always unwavering. So as we live behind a dystopian society where luxury is a stranger and poverty is a constant companion. I just want to join everybody to continue to have this collective commitment to the institutional progress of the Nigerian state. So, having said that, she defined HCI. So, Human Development Index. It basically has three key dimensions. Okay, there's the health part. That's how healthy you lived, which is measured in life expectancy. There's the knowledge part, which is how knowledgeable you are, how was access to education. And also there's the standard of living, which is measured by the gross national income per capita. The Nigeria's HDIs, I think, is around 0.532 back in 2017, which puts us in a low human development category. Now, if you look at the low human development category, we're actually lower than the average. I think the average is around 0.54 or something like that. So if we dive further and we look at the sub-Saharan part of Africa, we are lower than that average. When we compare ourselves to places like Congo or Ethiopia, which are kind of very common, very similar to what we have, you notice that our life expectancy in Nigeria right now is 53 years old, 53 years. And it's only changed by 8 years in the last 30 years. Okay? It used to be 45, and now it's like 53. So that's not good. Now, if you compare our life expectancy to Congo and Ethiopia, we are much below. Ethiopia is like 65, Congo is like 60. But the most important thing is, if you look at the GNI, which is the standard of living, ours is much higher than people in that category than Congo. So how come our GNI is much higher, meaning our standard of living is much higher, but our life expectancy is much lower? That tells me that there's a problem with healthcare delivery in Nigeria. There have been a lot of things that have been set up, Primary Healthcare Act, There was the development initiative that was done before in 1946 to 1956, which actually brought about 10,000 general hospitals. That was a lot of big development. But the Primary Health Care Act has not really met its goals. The National Health Insurance Scheme that was introduced in 2005 has not really met its goals. So there's a lot that needs to be done in the healthcare delivery, and there's so many problems that have faced us. If you look at healthcare access in Nigeria, only 43% access. Most of the healthcare delivery in Nigeria is usually from the private sector. 70% is from the private sector. Compare that to Ghana, where 90% is from the federal government. We have 300,000 general hospitals. We have 20,000 public health centers. We have 59 teaching care hospitals and things like that. But it has not translated into better life expectancy. So there are a lot of things. I don't know if you want me to talk about the things that plague all this, We'll come back to that. Okay.
Thank you for that. That's really important context. And you touched on healthcare delivery and the systems that require investment in order for us to actually deliver health to the populations that are in dire need of them. Dr. Kechi, could you speak to that a little bit and offer your own thoughts on our Human Capital Index and what the government is doing to respond to the healthcare situation in Nigeria?
Thank you, and good morning to everyone here. Without much ado, just going straight to that question, I think, I love to look at things that have the glass half full than the glass half empty, and but still, with that, we have to also be critical and use a critical lens to look at the situation and determine how we're going to improve, rather than, clapping and, being happy and proud of ourselves. Like Dr. Olurotimi just mentioned, I think just adding to that is when you look at the economy of Nigeria or Africa. I mean, we're about 430 billion, and the next African country, we dwarf them, and then, but when you look at the healthcare, and you look at the Human Capital Index and where we are, it's, it doesn't make sense. And a big part of that is really what we invest in healthcare. We know that the government puts down about, the trajectory is 8% of the economy into healthcare. But as of 2 years ago, it was still just less than 4%. So we're not even half of what is expected. And if we really are going to move in terms of the index, we have to make a very, concerted effort, and we have to really mean it when we say it, put our money where our mouths are. And, we have to invest in healthcare. We're even, when we look at the current investments, it's very sad, like you mentioned, that, a large portion of it really goes to the private sector. What are we doing with our public healthcare system? I mean, I have I'm lucky enough that I worked in probably about 90 countries, and I've had the opportunity to see their health systems. And, it's very, we're blessed because, there's a healthcare facility in a 5-kilometer radius of every individual in Nigeria. That's not something any other developing country has. Most people, it's within a 25 kilometers radius. So we have this public healthcare system, and then, our mortalities and our Human Capital Index is still so low. So I know we're probably, I don't want to dive too much into this, but there are so many things that we need to do. We need to look at, conflicts. We need to, peace is an important thing. I remember about 23 years ago when I had to go to Kano and we needed to give immunizations. And I was pretty much shipped out of, I had to be wrapped up just before the end of the prayers, because they said, the immunization we and the Americans came to give were all, the HIV virus. So, at that point I told all the Americans, I'm black, I'm Nigerian, you're on your own, and I could run out. But, it's sad when we have a lot of stigma and we have a lot of, social factors that are preventing us. That's just one, So conflict, peace, education, you name it. There are so many social determinants that are really responsible for where we are, and for us to make any headway, we need to really look at each of these determinants critically and come out with a very active plan on how we're going to move over, how we're going to deal with this. I mean, if you look at, I do a lot in preventive medicine. If you look at the best plans, I'm sure, my colleagues in the World Bank will tell you that Nigeria has the best. I mean, there are Harvard graduates and the rest. Boston University is better than Harvard, but, there are so many graduates that write all these papers, but it's so well written on paper. It's just not implemented as it's written. So, it's really, we really need to move from developing plans. We have them all there. If we want to talk about plans, stop wasting your money. Nigeria has the best. To say we pull them out when we're trying to replicate what we can do in Asia or the Caribbean or Latin America and the global world, we, when you think of something, you say, oh, get the Nigerian one and use it. But it's really now moving from what is written to implementation. Now stop.
So I think there's the big elephant in the room that one has to talk about, because you've just touched on it. In the course of service delivery, I think we find that there's always a lot of waste. There's capacity issues with actually delivering service, and then there's, of course, corruption. So I wanted to turn back to you, Dr. Olurotimi, so that we can just lay that out there. One of the things that I always push back on is corruption as the reason for everything, as the reason why we don't do anything in Nigeria. It's not the only reason, but it is a factor. And we clearly have challenges with corruption in our ability to deliver service. So do you want to speak to how to what extent that is a factor in the health care system in Nigeria, and how we might respond to that? Because I'd like to move now a little bit to the opportunities for responding to some of these challenges.
Okay. You want to talk about corruption? Well, in the realm of social medical choice, the rationale for growth is always vitiated by the logic of access denial. So what that means is that the problem with Nigeria is, like she rightly mentioned, we have all this infrastructure, we have all these things in place, but functionally, there's still suboptimal access to health. If you look at a population where 50% is living below the poverty line, which is $1 a day, and we don't have a robust national health insurance scheme, so it tells you that it's mostly pay for service. So how can people who earn less than $1 a day able to afford health? So, and that obviously speaks to corruption, because the minimum wage in Nigeria is still very low. A lot of people don't have food to eat. Like I said before, poverty is a constant companion. Luxury is a stranger. It's very difficult for people to survive. If you can't eat, it's very difficult. And health is actually a form of human capital. Health actually affects income, and income affects health. Most countries that are very poor, that the health is very poor, the health is bad, they're actually very poor countries. And poor countries usually have very poor health. So that is one of the things. So in terms of corruption, if the government and the people in charge put the people first, you have to engage the people. The vision is bigger than the visioner. The institution is bigger than the person. So it's not about all these infrastructures. It's not about the people in the government. It's about the people. That's why you're there. So if we can eliminate corruption, if we can have a patient-focused healthcare, not just have to do something for me to become the Minister of Health or something, I think we'll begin to make much of a difference. So I think that's probably one of the problems that we have. And like Dr. Kechi mentioned, there are all these infrastructure. The problem in Nigeria is not infrastructure. We have shell structures. I call them shell structures because they're not functional. We are creators, but we don't sustain. Without commitment, it's difficult to start something, but without consistency, it's very difficult to finish. So we can start, but we don't finish. We don't have a maintenance culture. And so that's probably, we have a perception, but perception without substance puts us in confusion. So if you have a perception, but there's no substance behind it, it's not functional, then it's not going to translate into anything. So the GNI is high. We're spending money, like you said, it's 4.5% healthcare per GDP. In America, it's 10%. 17%. In the UK, it's 10%. But we spend all this money, but we don't have anything to show for it. The healthcare, the life expectancy is still 53 years old. To think about that, the drivers of health, of income in any income or in any country, the economy, is middle class, working class people within the age of 25 to 55 to 60. And if you're dying before you're 53, how much can you contribute to the economy? So,
I think we're still on the very sober side of this issue, and I would really like to sort of continue on in that vein a little bit, because it is a very serious issue. But I want to talk a little bit about where the opportunities are for us to potentially use technology, for instance, or even the private sector to address some of these issues. Do you, maybe I'll come back to you on that, because I think you touched on a few important points, but maybe Dr. Kechi, especially with your experience in the development community, are there opportunities for us to perhaps partner with the private sector, have public-private partnerships in healthcare service delivery that can help us kind of address some of these challenges?
Just to go straight to your question, yes, there is. When we look at India, for example, India is a country that's, when you look at the public-private partnership, it's using the opportunities, and it's actually set up very similar to Nigeria, in the sense that, if I even do a quick survey here and ask people, when you had your first sign of malaria, how many of you just went, in Nigeria, how many of you went just to the pharmacy next door, or decided to go to call up your doctor or go to the hospital? I can very quickly say 90% of people that have lived in Nigeria would say, oh, I went to the chemist, right, next door, rather than say, oh, I called up my doctor, or I went to the teaching hospital. We're not going to do that. And that's also how healthcare is provided in a country like India. But what have they done? They've taken advantage of that. They've looked at what are the things that, how can we, I don't want to say exploit, but how can we maximize the opportunities with the private sector? How can we use the patent medicine vendors? So they've done a lot of tax shifting. And they have really, I think what Nigeria needs to do is to look at a lot of that, I'll say the primary delivery sector, so which is like the patent medicine vendors, the traditional birth attendants, and see how we can actually increase the quality of services. We can't continue to live in denial and say that, we're going to wait for doctors. Doctors are leaving. Hey, I was a doctor in Nigeria, I'm sure you were, and, we left, and we are not, we haven't come back yet. And, well, I won't say we're not coming back. My husband is here and is every day saying, let's move our bags back, so I'm looking forward to that. But, there's a lot of brain drain, even with the nursing sector. So we really need to look at who are the healthcare delivery service providers in a country like Nigeria. How do we formalize them? How do we formalize the patent medicine vendors? And I know, the jury's out on this, but a country like South Africa has shifted a lot, and we can see a lot of progress in their healthcare. They have, moved to, how do they formalize the community health volunteers? They are now part of the government system. How do we put them into the system? It's not just putting them in the system, but you make them accountable. So they are trained, they are certified, and they have to meet a minimum standard. And then you have to set up a referral system where they are recognized and they report to the formal health sector, to the nurses and doctors. So that's, I know there are different types of, private-public partnership. We also have to look at things like we talked about, people not being in the middle class and the economy and poverty. How can we use income generation as an incentive for women? I know that in Nigeria, like the Bank of Industry, I believe, is going into partnership where it goes in with the healthcare system to say, okay, if a woman comes, because our fertility rate is killing us. People are having 6 children, and then how do you take them to school? How do you pay for that? That ripple effect leads to unemployment. It leads to violence. It leads to robbery, and because people are unemployed. So how do you work to look at the root cause? So let's look at the fertility rate, and such private-public partnerships where they actually incentivize and say, okay, if a woman comes to get her contraceptive mix and all that, she then has a partnership. She can go to Bank of Industry, and I'm sure there are several banks, so forgive me if I'm just talking about this one I know, and they are then giving small-scale loans that are without interest. So that has helped a lot. That has incentivized women. We used to have women that wouldn't come during pregnancy for anti-malaria. That's and other things are the kind of private-public partnership that several countries have explored, and Nigeria, we need to look at that because the private sector still remains the driver of healthcare in Nigeria.
Thank you. No, that's really important, and I think in addition to the private sector being the primary driver, we also have, we're spending, I think, close to $1 billion in healthcare abroad every year, something ridiculous. I saw a figure that was quite astonishing. But there are models for us to follow. People have done it. Nigeria can do it. Dr. Olurotimi, do you think that there's opportunities for us to reverse this brain drain if we can put a few factors together that will support a resurgence in the health and other sectors that are so critical to human capital?
Excellent question. But before I touch on that, let me just say very quickly, we look at health as a univariate object. Health is not a univariate object. It's multifaceted. If you look at the microempirical studies that have been done, which are very compelling, the macro empiric studies that have been done, has shown that, it's not how health affects human capital also when. A lot of your physiological development and human capital development actually happens in childhood. Okay, so there's some things that happen in childhood that are very difficult to reverse. Like the critical periods in childhood are very usually short, and so if you don't invest in a child and the child has some disease burden that has gone into adulthood, that impacts the health care of that child. So if you look at the infant mortality in Nigeria, is 93 in 1,000. That's a lot. The maternal mortality, 50% of the maternal mortality in the world is based in sub-Saharan Africa, and after that 50%, 14% is in Nigeria. So that's a big problem that we need to tackle. I think one of the things that we need to do in Nigeria, before I answer your question very quickly, is, power is very central. And we don't talk about this, but it's very, very central, because if you can have power that is very consistent and very constant, you're going to have a lot of small businesses that are going to grow. the people will work, but they will find ways to develop other, small businesses which will drive the economy, because that's the backbone of the economy is small businesses. When you want to, if you want to start some kind of small business and you don't have power, it's a problem, because that is an overhead that you're going to have, and you're going to transfer that to patients. There's nothing you're going to do in any sector in Nigeria that you can sustain without power. I mean, I visited a cardiac renal center, which I was told to come and see, and I went there. It was a very nice center, but it was crippled because there was no power supply. They were spending 5 million naira every month to generate power. So that's something that needs to be taken care of. In terms of brain drain, health is one of the forms of national security. And so for people to want to go back, I think a lot of people in the diaspora want to go back. Dr. Kechi wants to go back. I'm sure she'll probably go back next week if she had the chance to do that. But, she wants to go back. I mean, but, there's no safety. There's no power supply. So if you want to cause reverse brain drain, you have to put in place things, systems, I call them systems, that you have to put in place to protect people and to incentivize people to want to come back. So that's one of the problems. And then the other thing is we have all these shell structures, but there's no personnel. We don't engage in personnel. Okay, so the government needs to engage all these people that are here. There's a doctor in our midst. He's a very expert surgeon. He's hiding somewhere there. I've seen him walking. We need to engage people like that and see how we can come back and put things in place. We need to have a forum. We need to have a conference. We need to sit down and talk to people and see how we can reverse the brain drain. Now, the question is, we need to ask the question, why is there brain drain to start with? Why people live in Nigeria? Even though we have all these things, it's nice. I mean, the expatriates are coming there, but Nigerians are leaving. It's economy. Everybody's leaving to find a better life, and to be able to provide for them. So if you can find a way to make, minimum wage and to increase minimum wage, put power supply, people want to come back and try to invest in the economy, and it will just naturally drive people back. It's not just about telling people to come back and there's nothing to come back to.
Very good. Thank you. And I'll just put one last question to you, and I might have time to take one or two questions from the audience. Given that there are a lot of investments that need to be made in the health sector and others, and until we get right some of these things like power and security, a lot of people will be trying to help from here. What can we do to partner with folks in Nigeria? Dr. Adeshola mentioned the traditional healthcare sector, for instance, and some of these modern day diseases that people in Nigeria are having to deal with. What can we do from here to partner with the healthcare sector and some of these traditional health service agents in Nigeria to support our human capital index? And what is Save the Children doing?
Well, I thought I'm here in my personal capacity, but there's so much that's already happening in terms of partnership with Nigeria. Let's look at an institution like the Global Fund. The Global Fund puts down almost $1 billion to Nigeria, highest country it puts money. But guess what? At the end of 3 years, we return about 25%. We do not spend that money. It goes and they're kind of in a trap and looking for where do we put this money, how do we spend this money. The US government, if I look at even my field, the amount of money, I think Nigeria is the third highest investment. But we can't continue to depend on international donors. There is, and what's also saddening is that we actually have the income in Nigeria, and we need to prioritize. We need to prioritize how we spend our money. So just to your point on looking at the traditional health sector, right? How much of the money that we put down, the 8%, actually goes to working with the traditional sector? 0%, because we don't recognize them. But when we look at the Western world, when we look at here, that's what all this, sorry to my acupuncture and holistic believers, but that's what it's all about. We've just modernized the name. How can we get, those leaves that, where we know that contains such a high amount of quinine? How can we use them? How can the pharmaceuticals start investing? The pharma industry, there's so much in the natural, natural resources that we have in Nigeria. Those are the kind of things that I'm hopeful. Like I said, I like to look at the glass half full than empty, that we can start, looking at from here, or where we can do some kind of south to south exchange and saying what are the resources that in Nigeria that we can use. Some of us, I'm sure lots of people here spend a lot of money going to the Whole Foods or the Mom's Organic to go and buy all the fresh orange juice, and you're paying an arm and a leg, and then 2 weeks after paying so much, I go to Nigeria, I go to Benin, I go to Niger, and I just see all the oranges on the floor rotting, and I know how, and I just feel like taking that and putting it into a machine and just drinking it, right? So how do we look at all the technologies that we have learned here and partnering with the health sector, or even, I think, I'll challenge ourselves and say the informal health sector in Nigeria, to start, looking for how to invest and do better things for healthcare. How can we use data? I do a lot of infectious disease, and it's almost like pulling teeth to get data from Nigeria. How do we use our technology? I mean, everyone is on WhatsApp or Facebook. How can we use all that technology to strengthen data collection so that we can know where to invest? How can we use technology to look at, the whole geospatial mapping to know where the hotspots are for different diseases, and then be able to direct our funding so it's targeted. It's not just, you put money all over the place. I mean, there's still data. How can we work in northeast Nigeria? When we even look at our data, I mean, the south and the north, we look like, two different countries that's probably generations apart. How can we now look at the southeast of Nigeria and help with the immunization rates? The maternal mortality rate, yeah, that's the average, but when you actually represent it by geography, the story is very different and it's very troubling. So those are the type of partnerships that we want to bring into Nigeria. But last point before because this is, I'm very passionate about this. The last point I would make is that, investment we have to, and commitment from the diaspora has to be met with a willingness and eagerness on the other side. Because I know that there's so many, we have the AMPA, the Association of Nigerian Physicians in America, and I sit down with lots of people and they've said, I'm taking I want to start a dialysis center, but even just getting a license to set up something in the country is like, it takes them 3 years. So we need to kind of meet ourselves halfway. We have to really be committed to helping the West, and then the West, I think we also have to respect the institutions, because sometimes this $1 billion I refer to comes with a price, and we have to respect the Nigeria system, that Nigeria has a state, a local government, a federal system, and we can't impose our ways on them. So those are, I'll stop here again, and I'm sure we can talk.
Thank you. So we're pressed for time, so let me see if I can just take one question.
Excellent question. I always say if you want to run fast, you can run alone. If you want to run far, you run together. Also, you can't possess inheritance by ignorance, but you can possess ignorance by inheritance. So we have to, just like you said, there's got to be a medical bridge. It's not enough getting people to come back to Nigeria, treating patients and doing all these things, but there has to be knowledge transfer, because you can go there and just treat patients, for some days and go back. It doesn't make a difference. You have to find a way to transfer that knowledge and train other people so you can propagate what you need to propagate. Greatness has an intimate relationship with inevitability. And Nigeria has a greatness, which is inevitable. But we have to be intentional about what we want to do. And we have to engage, just like it says. We can start with a forum. Call people in the diaspora, get somebody to bring people together, and also invite the local, the other people on the ground. And so we can find a way to merge things together and come up with ideas, just like we're doing now. We're coming up with ideas with this program. Come up with ideas and look for a sustainable way to transfer knowledge, bring people back, let them become part of some teaching system, so that they have a way to feel that they are part of the system, not just coming back to treat patients and then you go back every week. If you make them part of the teaching system, then they have a commitment to come every year or twice a year or something like that, and then find a way to bridge that gap between Nigeria and the diaspora, so that that knowledge, technology, whatever it is, can be transferred and can result to a more sustainable thing. The last thing what I want to talk about, just to his question, is Nigeria, we build big hospitals, and they're not really specialized in anything. We don't want to be a momentary master of a fraction of a dot. It's not just about building all these big hospitals, and we don't have a center that is a specialist center. At least we can be known for something. Let us be known for something, even if it's just some part of medicine, preventive health care, OBGYN, surgery. Let's create a center of excellence. Let's start from there. We don't have to build 15-story buildings to make a difference. You can build only one-story building that caters to just a specific type of illness, so that you can become a master in that. And then you start propagating that in different places, so that you know that if you go to Lagos, you can get this. If you go to Abuja, you can get this. Not having all these 15,000 hospitals that is a master of nothing.
Thank you. I think, okay, so I'll take one more question. There's one in the back. Thank you. That's a great question, and we have a movie producer who's here today, so maybe later he can even speak a little bit about this, because I think it applies to all sectors where we need behavior change as well as the investments in order to really transform. So Dr. Kechi, would you like to speak to this a little bit? I really love that question.
Yeah, it's like, it took some of my brain. And I was coming back a few days ago from somewhere, and on the flight, I decided to, unfortunately, sadly, I don't watch Nigerian movies, but I decided to watch a Nigerian movie, and it was one about a young girl, a Bini girl, that hadn't got so married, and her family was putting a lot of pressure on her, and I chuckled all through, because it reminded me of myself, actually. And so to your point, I really said the same thing. I said we need to tap into the Nigerian movie industry. If you go anywhere in Africa, it doesn't matter how you sound. Once I say my name is Kechi, they say Nigerian, they start asking me, do you know Genevieve something, or there's just because all over Africa, Malawi, Zambia, it's all about Nigerian movies, and how do we use, so that's a big force. And the sooner we start tapping into the Nigerian movie industry to change behaviors around health, the better for us. So I think, like you said, that is really a fertile ground that when we talk of public-private partnership, we need to do that, work with the private sector or the movie industry, and see how we can use that industry to create better health.
Thank you very much. I would have felt like a failure if we didn't conclude with solutions, and I think you've both offered a few. I think there are lots of fora that are starting to think about the ways that we can come together, work together, and invest in Nigeria. We've talked about partnerships with the private sector, with government that's respectful of the structures in Nigeria. We've talked about the movie industry ended there, which really pleases me, because even in the World Bank, we're thinking about how we can partner with some of these forces for change and forces for good that will help us address behavior change, which we understand to be a key factor in our ability to actually achieve success in a lot of our human development outcomes. So thank you to both of you. I cannot possibly summarize the conversation that we had today, but I do hope that it's been enriching, that everyone here has gotten at least one idea. I know that I picked up like 10 quotes from Dr. Olurotimi. You're the master of quotes. And I wish I could have been writing them all down, but honestly, you have a really compelling way of, making one think about the challenge and the opportunity. And Dr. Kachi, your immense passion for this sector really came through. So thank you to both of you, and we all are tremendously enriched as a result of this, and I hope we'll have the opportunity to go forth. I'll allow you to end.
Thank you. I just want to make one last point, because I know she's mentioned something. I want to conclude without making a touch of what she talked about. So last, I just want to say, let's de-westernize our food. One of the problems we have in Nigeria is westernization of our diet, which is increased incidence of hypertension, obesity, diabetes, kidney disease is an epidemic in Nigeria right now. Cardiovascular disease also because of the Western diet. Just like she said, the herbs, the fertilizers, they contain nitrates, which cause gastric cancers, all types of cancers. And last, I just want to remember one thing. Let us take food as medicine and not medicine as food.
Thank you. Thank you. You want to say anything?
My last closing remark is for gender and women. Women are such a big force in Nigeria. Women have a big impact. Our fertility rate is really high, and our fertility rate has a ripple effect on, social determinants of health. So I think if we're going to be able to make any meaningful change, we really need to prioritize women in Nigeria and the potential for women in Nigeria. So, let's not call gender and gender inequalities as lip service, but we really need to think about the potential for women and what women can do, and build on that.
Thank you to you both. Thank you.
Thank you, Dr. Achebe and Dr. Badero.